let's move on to our next topic, metastatic triple-negative breast cancer. This is an area that's heating up, thankfully, because again, a very high unmet need. About 15% of all breast cancers triple negative being defined by what the tumor is not, so not a very sophisticated way of defining a tumor subtype. We had the FDA approval of atezolizumab in combination with nab-paclitaxel recently based on the IMpassion130 data. And this was for patients whose tumor immune cells were PD-L1 positive, which is about 40% of metastatic triple-negative breast cancer. But the KEYNOTE-355 data was presented at ASCO, looking at another immune checkpoint inhibitor, pembrolizumab. Aditya, can you give us an overview of this study? How did the design differ from IMpassion130, and what is this CPS that they used?
Absolutely. So similar to IMpassion130, this trial looked at immunotherapy. The difference was that the drug was pembrolizumab instead of atezo, and looked at patients who had not received prior therapy for metastatic disease. And this was a first-line metastatic triple-negative breast cancer trial. Patients were randomized 2:1 to chemo plus pembro versus chemo. The difference between this trial and IMpassion130 was that the choice of chemotherapy was much more expanded. Patients were allowed to even receive platinums, carboplatin, besides the option of taxane, as was utilized in IMpassion130. Overall, the study was positive. It demonstrated an improvement in progression-free survival in patients who received pembro plus chemo, either taxane or carboplatin, as compared to chemotherapy without pembro. The statistical significance was seen in the CPS more than 10 group, which was defined as PD-L1 positive in this trial. And CPS is a composite score. It looks at both the expression of PD-L1 in the tumor as well as expression in the tumor microenvironment. So this is different from what was used in the IMpassion130 trial, where the approval was based on IC, or the expression of PD-L1 in the tumor microenvironment, more than 1%. And approximately, if we look at some of the data that's been presented, CPS is a more relaxed definition of PD-L1 positivity, so captures more patients as compared to the definition of IC that was used in the IMpassion130 trial. And more than 10% CPS approximately is equal to more than 1% of PD-L1 IC. Again, this is a very broad comparison, but conceptually they are equivalent based on what has been presented. The team also looked at CPS more than 1%, and you could see a trend in terms of improvement in progression-free survival, but based on the statistical method that was utilized in the trial, that was not considered significant, or it didn't meet the boundary. So overall, the study was positive for patients who had tumors considered to be PD-L1 positive as per CPS more than 10. And we'll have to see if the drug gets approved. It would provide another option for our patient. And the advantage of the study is that one could use a carboplatin-based chemotherapy backbone with pembro, which is attractive for our patients. I think the challenge is going to be these different assays. This trial used CPS. The IMpassion study used IC. At our institution, we use a different assay. So it's just going to get complicated from that perspective. From a patient perspective, it's nice to have a couple of immunotherapy options.
Yeah, I think it's going to be interesting to see how the regulators view these data, right? Because the delta in PFS was about 4 months in favor of pembro for patients with a CPS score of at least 10. However, there was still a 2-month benefit and a nice hazard ratio with the very nice looking p-value for those patients with a CPS of 1 or greater. And that comprises about 75% of patients with triple-negative breast cancer. So I can foresee a situation where a patient is negative by the PD-L1 SP142 tumor immune cell test, but has a CPS of 2, for example, and I would be inclined to want to add pembrolizumab to chemo. Claudine, I know I'm asking you to put on your, your vision goggles for the future, but how do you envision this, and what are you thinking we're going to be faced with in the coming months if this is approved? How do you think clinicians will sort through which assay to order and how to sort out which patients get which drug?
I think that's a great question, of course. And I think you also alluded to it earlier, in the triple negative population, this is a group of patients where we don't have a ton of great treatment options. So I personally, I'm trying to make my tent as big as I possibly can to try and offer them immunotherapy. So actually we talked to our pathologist after this got presented and said, could you run both assays? I mean, they do it. I live in a silo, so all I do is breast cancer, but they don't, and they do pan different tumors. And so, they were more than happy to throw on a CPS score for me, for my patient. So I guess what I have been viewing it as is I would like to, if possible, do both assays, and try and offer until we have better evidence, try and offer immunotherapy to as many of our patients with triple negative breast cancer as we can. I also, as Aditya mentioned, I was really happy to see that I had it really opened up the menu of chemotherapy backbones that I could use with it, because nab-paclitaxel is certainly a great option, but it's nice to have different options for different patients. And so the possibility of combining it with different chemotherapies was very attractive. But right now I'm sort of the mode of great, we have further supporting evidence that immunotherapy makes a difference for these patients with really an aggressive subtype of breast cancer, and I'd like to try and offer it to as many as possible.
Sarah, looking forward, if you have a patient who's been tested by both methods and they are positive, their score is 11 for the CPS and they're PD-L1 positive for tumor immune cells, how are you going to decide between atezolizumab or pembrolizumab, assuming pembro is approved? Is it only looking at the chemo options, gem-carbo versus taxane, or are there other factors that would put you in favor of one immune checkpoint inhibitor over the other?
I know it's a really good question. I think one factor that's definitely going to drive that decision is the individual patient and timing from, their prior adjuvant therapy. So one distinguishing factor in Keynote 355 is they did allow people who are greater than 6 months out from their adjuvant therapy, as opposed to Impassion 130, where you had to be 12 months out. And so, we do have almost, a quarter to a third of our patients are early relapsers with triple negative disease. And those are patients who've had taxane not too long ago, who we really do want to choose a different chemo backbone. And so in that particular situation, in a PD-L1 positive population, I would probably be using pembrolizumab in combination with platinum-based therapy. Whereas, you have a choice, though, in someone who's greater than 12 months out from their adjuvant taxane. And if you're going back to a taxane backbone, then you could choose between, nab-paclitaxel and atezolizumab versus a taxane and pembrolizumab. And, I think to your question, are there differences between the checkpoints that are going to help us pick one over the other? And, as we don't have randomized data comparing pembrolizumab to atezolizumab to know if one is more effective than the other. We don't know if blocking PD-1 versus PD-L1 is different from an efficacy perspective. Interestingly, there is some data to suggest toxicity may be greater with PD-1 inhibition compared to PD-L1. Some very robust meta-analyses do suggest that PD-1 therapy is associated with higher rates of immune-related toxicity, and I think we can see this when we look across trials as well. That being said, it also does make me wonder if efficacy may be a little bit better. We do see some trend with greater immune-related tox and higher efficacy, and we just don't know. Again, we don't have robust randomized data, at least in the metastatic setting. Interestingly, there is one small trial that is actually comparing the at least three checkpoints. It's the Contessa Trio trial, which is taking patients who have triple negative breast cancer and randomizing them to an oral taxane, in this case Tessa-Taxel, either with atezolizumab or pembrolizumab or nivolumab. It is not robustly powered to compare the checkpoints, but I think it will provide some really interesting biomarker data in a randomized setting to look at predictors of response. So hopefully we'll learn more.
That's going to be very exciting to see that. I think that's something we're all very interested in seeing as we navigate these new waters. And to round up this topic, I think an important thing you touched on, Sarah, was toxicity. So Aditya, can you talk to clinicians right now and give sort of your advice on what to expect in terms of immune-related toxicities? Now, we don't need to talk to our colleagues who are treating lung cancer and other cancers where immune checkpoint inhibitors are very commonly used, but for breast oncologists like us, this is sort of a new era. What should we be watching for? How should patients be monitored? What's to expect?
I think the bottom line is early recognition and intervention. You can have toxicity pretty much in any organ from immunotherapy. You can have GI toxicity with colitis that would manifest as diarrhea, LFT abnormalities because of immune-related hepatitis, pneumonitis because of the impact on the lung, as well as various endocrinopathies, in particular, the impact on the thyroid gland. Hypothyroidism is a common AE that is observed with immunotherapy. So monitoring of TSH as well as the thyroid hormones would be critical. And I would come back to the point that early recognition is going to be critical. As different from other drugs like TKIs, these toxicities can occur late. You can have these toxicities 3 months, 4 months, more than 6 months after the start of immunotherapy, but can also occur after 1 or 2 doses. So I think the key is to be cognizant that pretty much any organ can be affected, and if a patient is complaining of a symptom, that needs to be evaluated further.
Excellent. Thank you for that. So let's move on to another topic that is relevant to triple-negative breast cancer and is also very hot and exciting, and that is the use of PARP inhibitors in triple-negative breast cancer. PARP inhibitors hit the scene recently for patients with germline BRCA mutations, which comprises about 5 to 10% of all metastatic breast cancer. But many have wondered whether or not we can be using PARP inhibitors in patients with tumor somatic mutations in BRCA or other DNA repair pathway deficiencies, either germline mutations or somatic mutations that would lead to DNA repair deficiencies. Now, we all remember the O'Shaughnessy experiment with gemcarbo plus or minus aniparib, a great disappointment after a lot of excitement. Turns out aniparib was probably a promiscuous inhibitor of many, but not much inhibition of PARP, and that may have been why we saw these negative results. But enthusiasm is now regenerated in addressing this question, this hypothesis, and we saw a couple of studies report out at ASCO that were very exciting. And so Claudine, can you take us through these SWOG 14-16 study that Priyanka Sharma presented looking at veliparib in this setting? Can you talk about the study design a little bit and the results?
Sure. So this was a randomized phase 2 trial. It enrolled just over 300 or so patients, and the randomization was really to cisplatin alone or cisplatin plus veliparib in patients with triple-negative breast cancer and patients who are known to have germline mutations in BRCA1 or BRCA2. And what they did as part of that trial, in the patients who did not have a germline mutation, they actually looked for evidence of deficiency, tumor-related DNA repair deficiency by the HRD assay, and they called those patients BRCA-like. And so what they found overall in this trial was there was actually a very small number of patients who had germline mutations. And while there was a benefit for the addition of veliparib for that group of patients, it was not statistically significant. But it's possible that that was just driven by the small numbers. For the patients who had BRCA-like tumors, and that was just under a third of the patients, there was actually a prolongation in progression-free survival and overall survival with the addition of veliparib in that study. For the PFS, it was statistically significant. It was just about 1.7 months. And for the OS, it did not achieve statistical significance, and it was just under 2-month prolongation. But in the triple-negative, non-BRCA-like, there was no hint of benefit for this agent. And so again, I think this brings back up the question of how we look for tumors that may respond, patients with tumors who may respond to PARP inhibitors. And it was another interesting presentation I'm sure we'll get to in a moment on this issue. But within the triple negative subtype, it re-raises that question whether we should be doing some assay to look for HRD status, because that might drive and identify a subset of patients where we would have benefit from PARP inhibition.
Yeah, I was really struck by how poorly the non-BRCA triple negative breast cancer patients did overall. It's certainly an area of unmet need, and I'm sure all of us would love to see molecular data. I know that data is being evaluated on that study and will probably later be presented, but what's going on in operating to make these tumors respond so poorly to chemotherapy-based treatment? Along those lines, you brought it up, there was another interesting abstract that was presented. The TBCRC 048 trial evaluated olaparib in patients who had somatic BRCA mutations in the tumor or homologous repair deficiency due to germline or somatic mutations in DNA repair pathways. Sarah, can you go over this trial a bit and their results?
Sure. So this was a TBCRC trial that was led by one of my colleagues, Nadine Tung. And she, again, as you said, was really looking to see, does olaparib have activity outside of the traditional germline BRCA cohort where we have seen very robust efficacy. And so the trial enrolled patients who either had somatic BRCA mutations or could have germline or somatic alterations in other pathways that are involved in DNA repair. And so, honestly, I think this was really a very impressive finding that we saw at ASCO, where they found that amongst those patients who had germline PALB2 mutations, and again, this was a small number, it was 11 patients, but out of the 11 patients, there were 9 patients who had an objective response. So it's 82% objective response rate. And the other 2 patients actually had stable disease. So it's 100% clinical benefit rate. Again, very small cohort, but really astounding, in terms of efficacy. And they are going to expand this cohort of patients to enroll more patients with germline PALB2, to validate the efficacy that they're seeing in a larger cohort. But truthfully, this finding would make me think of prescribing olaparib in someone with a germline PALB2 mutation if I didn't have a clinical trial option for them. And I think the other finding that came out of the study was that patients who had somatic BRCA mutations had a 50% objective response rate. So this was, again, a small cohort of only 16 patients, but really showing efficacy that's really in line with what we see with germline BRCA mutations. So, the response rate, for example, in the Olympiad study was 60%. So we're really on par with that kind of efficacy. And so, it does make me think of prescribing olaparib even for a somatic BRCA mutation. And we are picking these up more and more as we do get, now we often are even getting ctDNA assays in patients later in line in therapy. I know Aditya has actually done some very nice work on this, looking at the ability to pick up somatic BRCA mutations on ctDNA. So I do think it's a very important finding.
Yeah, I agree. I was profoundly moved by the data. I think this is incredibly exciting, and it's what we've all been hoping we would see when our hopes were dashed by the aniparib data. It's sort of a reawakening of hope. These drugs are pretty well tolerated, certainly in my experience, better tolerated than chemotherapy, and it keeps patients out of the infusion room. Aditya, what's it going to take for this to become used in practice, maybe even an FDA approval? Are we going to need a large randomized clinical trial? These are rare subtypes of breast cancer, and it's not rare, but it's not 20% of breast cancer. So to enroll a large trial would be quite challenging. Where do you think? Are you ready to use this in practice? What do you need to see to be comfortable?
Maybe years ago, we would have needed a randomized trial, but the FDA is much more flexible now, and we've seen drugs being approved based on single-arm studies, especially for mutations that are rare. And if we see a response rate of 50% in a larger data set, I would say maybe closer to 80 or 100 patients, I think a case could be made for potential approval of this agent for this rare subtype of breast cancer. Off-label, we are using it. I'm with Sarah. I have used olaparib off-label for patients with somatic BRCA mutation if they are not eligible for a trial. So in practice, they are being used off-label. If we can demonstrate the activity in a well-defined, homogeneous patient population, a case could be made for approval of this agent.
Yeah, I agree completely. So I'm excited to see more data. I know there are a number of ongoing trials to hopefully validate these very promising data from these two abstracts. So I want to turn gears now a little bit to a very clinically relevant question that I've struggled with for the 14 years I've been in practice now. And that is when you have a patient come to your clinic with de novo metastatic breast cancer and an intact primary. This is a problem we only see probably on the order of 10% in the US due to screening and sort of aggressive early treatment of patients. You see it more commonly in other countries where access to screening is a little bit less available. But certainly is a clinical question. Do we take them immediately to surgery? Do we do axillary dissection and radiation? Or is systemic therapy, now that we've gotten so good at systemic therapy for the majority of breast cancer, is that adequate? And so Claudine, the ECOG-ACRIN study was presented at ASCO. This was a fourth randomized trial that I'm aware of to address this. Can you tell us about the results and how we should be applying these data in practice? What did this study not address and what did it address?
So this was another reasonably sized trial that randomized patients who presented with de novo metastatic disease, triage them in a way that I think we would do in practice, right? You don't want to take every patient up front and take them to surgery, but you want to take the patients where you have evidence that they have disease that is responding to systemic therapies, the ones where you think you might have an advantage from doing this. And so it enrolled patients, it treated them for about 6 cycles or so, and the patients who were not progressing, they were then randomized to go to early local therapy or else to just continue on systemic therapy and have local therapy as a salvage. And the rationale for the study was really based on registry data primarily that suggested a better outcome for patients who had local therapy, who presented with de novo disease. And of course, that is very much fraught because it reflects what we do in practice. We cherry picked the patients that we thought would do well and sent them for surgery, and the others that didn't, we didn't. And so there were huge biases in those trials. And there were two other randomized trials that we've seen results on that gave us some conflicting answers about whether there was a role to early local therapy. So Seema Khan presented these data at the plenary session, and there was absolutely no benefit in terms of overall survival for the patients who went to early local therapy compared to those who continued on systemic therapy and just had local therapy if they had issues that came up. There was better local control, which was, they weren't huge numbers, but about a quarter of the patients or so got into problems and needed some local therapy, but there was no survival benefit. And that was true whether the patients had hormone receptor positive or HER2 positive disease. There was actually a small subset of patients with triple negative where the suggestion is that they actually did worse if you interrupted their systemic therapy, presumably to go to local therapy. So I'm grappling with this, honestly, because these trials were, they all suffered from various issues. Seema's trial was a great trial, but it had a really difficult time to accrue, and it reflects what we do, right? We sort of thought we knew the answer, so we didn't want to put the patients on, or we and our patients didn't want to be randomized to a question like that, and so I think we still have some questions. I guess I still grapple. I have a few patients in my practice who had oligometastatic HER2 positive disease, and where I've grappled with, should I be doing local therapy for them because I know their lifespan is so long, maybe it would actually make a difference. But I think overall this tells us that as a routine, we absolutely should not be doing early local therapy in our patients. And I think there might be individual patients where we would think about it with these data in hand.
Yeah, I agree. I thought the data were very compelling. It certainly didn't address the question, as you mentioned, of oligometastatic disease and whether SBRT might help in that situation prolong the progression-free survival or overall survival when done with local therapy. But right now, we don't have data to support we're helping patients. Sarah, did you notice the quality of life data, which I thought was very interesting, because my sense has been that it's patients who drive the move toward having surgery, get the tumor out of my body. And so I was actually surprised to see the quality of life data not really support that patients feel better having it removed.
Yeah, no, that was actually really interesting that the quality of life was lower in patients getting local therapy at an early time point. I think it was like at a year and a half, whereas actually when you follow them for longer, there was really no difference in quality of life between the two arms. But, I think it is to your point that, not only were patients experiencing worse quality of life, but they also got no survival benefit out of it. And so I think, circling back to what Claudine was saying, I think it is really a selection issue that, these data certainly do tell us that in general, there is no role for local therapy in these de novo patients. However, I also still struggle because, we do have some data that for patients with oligometastatic disease that SBRT can have a survival benefit. This study did not allow for treatment with SBRT for oligometastatic sites. And I think the other thing is that the data on subgroups is challenging because there are small numbers in each subgroup. And, I think many of us wonder for HER2 positive disease, as we get better and better biologic therapies, if we potentially would be able to cure someone with de novo metastatic HER2 positive disease, if we were to incorporate, for example, local intervention like SBRT. And so, I still think that while this definitely suggests no role for local therapy, I still think there's room to explore this question a little bit further, particularly in patients where we do have such good systemic drugs, and now that we have SBRT available. So hopefully there will be more studies to address these in those more narrow niche populations.
Yeah, I mean, our systemic therapy is so good, as you mentioned, and I always go back to that oath we took, first do no harm. So if we're seeing a quality of life detriment and no improvement in survival, I think I agree with what you both have already said, which is we need more clinical trials to specifically address that question. Again, these trials take a long time to enroll, given that this is not a super common thing that happens clinically. But when it does come up, I think we all struggle with it because our gut instinct tells us more is better. But many times in oncology, more is not better.